So I want to thank the organizers for inviting me to speak. It's so exciting to be kind of part of this. Before I get started, I wanted to reveal that I have no conflict of interest, but I'm happy to entertain any. So if there's anybody here that wants to. But today we're going to talk about some of the advances in the management of non-small cell lung cancer. One of the things that I have found, I've been in practice for about 8 years now at the University of Washington, is that just because we have new technology doesn't necessarily mean that we actually need to use it and that it actually advances clinical outcomes. And so I'm going to talk about a few things. Some of the objectives for today is we're going to understand the basics on lung cancer, just a few things I'm going to talk about that, discuss some of the new techniques and technologies in radiation oncology, and then understand some of the current data available using these techniques. Just to give people a roadmap of where we're going to be going today in the next 15 to 20 minutes, is we're going to start with some background, then talk about SBRT, which I do think is a great technology that can help both in the United States as well as in developing countries. Talk about Calypso, which I'm very much on the fence about if that has any role at all, and then IMRT, which I think we should hold off on, and then talk about planning, actually, and the use of PET, which I think is actually, we talk about it a lot in terms of diagnostics, but I think it also plays a major role in radiation oncology as well. So we know that in terms of lung cancer, there is a large percentage of patients in the world that have lung cancer. In the United States, it's about 1 in 15 Americans. In the world, it's about, I think there's about 16 million cases that are seen every year. Unfortunately, about 15 million cases die every year. So we are not hitting any kind of home runs or making any goals in terms of this. So we definitely need to partner with other countries and people that are smarter than those of us that are in the United States to make sure that we actually improve our outcomes. So in the US, if you look at cancer sites in terms of death rates that are estimated, lung cancer far outdoes even if you add breast, prostate, and colon cancer, which are the most common cancers in the United States. And so, like I said, it's going to be very important that we do a lot of work together on this site. So I'll start by talking about SBRT or SABR. So conventional radiation therapy that we do with the linear accelerator that we've been doing for years and years. Commonly, this goes from 60 to 66 gray for lung cancers. For early stage, often that's given in 2 gray fractions. From studies, we know that there are about 15% long-term survivors, 25% death from intercurrent illnesses, 30% death from metastatic disease, and only about 30% death from local failure alone. What we do know is that the last speaker was kind enough to kind of introduce the idea of dose in terms of how important that is, and it is important in terms of how we deliver it. We know in lung cancer, if you look at retrospective studies looking just at stage 1 patients, there is a cutoff between less than 65 gray and greater than 65 gray. In prospective dose escalation studies, we know that doses actually greater than 80 gray have resulted in local control and overall survival. Again, I'm focusing only on early stage patients, stage 1 and 2. So we do know that there's possibly an increased dose may improve survival. That really set the stage for an extension of some of the existing technologies that exist in the United States. Specifically looking at the combination of gamma knife with 3D conformal radiation therapy, we came up with something called stereotactic body radiation therapy. For those that aren't familiar with this, basically we do a number of different angles where we're using the radiation beams and it's focused on a small spot, usually less than 7 centimeters. Usually it's one site of disease, and we're able to go to a very high dose over very few fractions. As opposed to delivering radiation therapy over 33 fractions, we usually deliver it from anywhere from 3 to 5 fractions. Far more convenient for our patients, and we'll talk about outcomes in just a second and how those are also important. Like I said, it's used in primary or metastatic lesions of the lung, liver, spine, retroperitoneum, and pelvis. Some of the key features, it's an extracranial, basically is the targets for this technology. We use a body frame. Like I said, we want it to be less than 7 centimeters usually. Our dose regimen is usually anywhere from 36 to 60 gray and anywhere from 3 to 5 fractions. Very convenient for patients as opposed for them to come 6.5, 7 weeks. They only have to come for a week or 2 weeks. Targeting accuracy is about 5 millimeters, and we do need to use some kind of respiratory control because tumors in the lung, not surprisingly, move. Staging, of course, of these patients must be optimal to make sure that we are using this technology appropriately. In the US, we usually do it for stage 1A, 1B, and select 2B patients. We will often do a CT of the chest for these patients, and a PET is pretty much essential for us. You also want to confirm suspicious nodes by mediastinoscopy. This is what the local control rates we've seen. We have numbers that are actually just coming out at 10 years, and the numbers kind of stay about the same, somewhere between, usually they range from 80% to 95%. So we're seeing lots of different, really improvement compared to traditional radiation therapy. I want to remind everyone that the local control and the overall survival was very low, which is traditional radiation therapy. We were talking 15%, and the local control was, like I said, about 33%. So this is a huge jump up, much more convenient for patients and much better outcomes. One of the first institutions that did this was Indiana University in the United States. This is one of the slides from Bob Timmerman. His 2-year local control was about 95%. When the RTOG kind of replicated this in a phase 2 study, they looked at this in a median follow-up of 34 months. Their 3-year local control was 98%, and their median overall survival was 48 months. So clearly huge leaps that we've made in early stage lung cancer, and something that not only is convenient for patients, but also improves outcomes pretty significantly. So I'll switch tracks, and so going back to summarize on stereotactic body radiation therapy, I do think that that is something that developing countries should definitely entertain, hopefully fairly early on when they are adding their linear accelerators, because it's difficult for patients to come every day for radiation treatment. So let's switch over to Calypso. There's a few institutions in the United States that are using this technology. The reason they use that is because there's some limitations with the current methods that we deliver radiation therapy with. The therapeutic technologies, we want to deliver highly conformal radiation therapy, tight margins, increased dose. There's some barriers though. When we set patients up, we have to make sure that they are exactly still. There is patient motion. Patients are sometimes uncomfortable if they lie on a table for an extended period of time. There's organ motion. Organs in the body move often, particularly those that we focus on with this talk with lung cancer. And there's also tumor geometry changes that happen. And so to improve disease control and reduce complications, we can use a technology called Calypso. So what is Calypso? Calypso is basically a GPS for the body. It's a wireless miniature beacon electromagnetic transponder, very small, it's about 8.5 millimeters. And basically you implant it into any kind of solid tumor. It's most commonly done in prostate cancer, but there are a few institutions, like I said, that are using it for lung cancer. And so the question is, does this more accurately target our tumor so that we can have highly conformal therapy and basically have patients that have less side effects, so we can do things like dose escalation, like the last speaker mentioned. Just so people know what Calypso kind of looks like, this is a patient, this is from actually Calypso itself. They provided this slide. There are these implanted beacon electromagnetic transponders that are put into the patient. There's a 4D console that sits in the room by the linear accelerator. There is a 4D electronic magnetic array that sits right above the patient. Then there's an optical system that also sits in there. And then the therapists are actually outside of the room looking at a 4D tracking station. They're looking at a screen that is actually similar to this one right here, and they get the movement of where those transponders that sit in the body actually are doing. And so this is just kind of a very brief overview, and what you can see is as the tumor moves or whatnot, you can see kind of the movement of where these beacons are. And they're accurate to within, like I said, 0.05 centimeters. And when they go beyond a set threshold, they alert basically the radiation therapist and the radiation oncologist. So like right here is well beyond our threshold, and so the radiation therapist can stop the machine to make sure that the patient is safely being treated. That being said, I don't think that Calypso is something that is ready for prime time, both in the United States as well as in developing countries. So just because we have this technology doesn't mean necessarily we should use it. It is something that I think people should know what the limitations are, and something that could be exciting. I'll briefly also talk about IMRT. So for those that don't know what IMRT is, intensity modulated radiation therapy is kind of a way to deliver radiation therapy, and you're compared to conventional radiation therapy, which is this wedge pair here where the radiation comes from both sides and kind of targets this tumor, versus say a 9-field intensity modulated radiation therapy plan, where you're basically able to carve around the spinal cord and the heart and the esophagus, which in theory actually sounds great because you can avoid a lot of those normal structures. I personally don't think that this technology is necessary just yet all the time, and the reasons that I have limitations for it is because I think tumors move, and that makes it difficult because intensely modulated radiation therapy has sometimes some very sharp dose fall-offs. Dose calculations in terms of their small field heterogeneity, I think that this becomes an issue. You also worry about large volume, low dose from normal tissue complications. But sometimes, you don't really have an option and you need to carve around a certain structure. And so you can maybe consider a radioprotector. That was mentioned earlier in one of the talks, and so it's something to consider. I always start with a 3D conformal plan, and then if I can't meet it, then I tend to switch to intensity modulated radiation therapy. And that's really, I feel like, the appropriate use for this technology. And I know there's probably people in the audience that disagree, and I'm happy to kind of have that conversation. So let's switch over from some of those technologies to planning. Specifically, I think that when we talk about new technologies, it really requires very careful planning. Treatment planning can't make up for drawing the wrong volumes. My dosimetrist taught me that very early on, that you need to make sure that you're drawing what you actually want to treat, and so that they can accurately do their work. And of course, we talk about some tumors are actually radio-resistant. They're like, oh, this tumor is not going to respond to radiation therapy. But I think one of the sayings that we had that I learned very early on was the most radio-resistant tumor cell is the one that's actually not in the field. So we need to make sure we're accurately defining these tumors so that the work we're putting in to treat these patients actually makes a difference. So let's start and talk about PET very briefly. PET, this was a patient that we had very early on, and I will tell you, before we had PET scan, we'd have the tumor that kind of sat right here, and we just kind of contour that out and treat that. With the advent of PET, you can see that this clearly goes well beyond the chest wall here, and it actually goes beyond, so our margin actually included the entire tumor. If we hadn't had the PET scan, we actually would have missed part of the tumor. It also helps in cases like atelectasis, where you have a collapse of a lung. Here you can see where the tumor actually sits, and so we actually did not have to treat that entire area. And I'll actually show a cone beam CT to see what the end results of that were in just a second. What I would encourage is, I know that as we get new technology, say 5, 10, 15 years from now and add a PET scanner, you need to watch when you co-register those with CT scans. We used to do a CT and then a PET registration, and we were definitely off in terms of the area we wanted to treat. And so that actually didn't do any of us a whole lot of good because we weren't accurately, again, treating the tumor. And so what we've done now is we actually take our immobilization device, take it to the PET scanner so that these co-registrations happen more accurately. This is just an example of what we do now. You can see kind of where the tumor sits, and it's pretty accurately captured here. The other thing I'll help, and I did want to put this in, Mike and I got a chance to talk a lot over the last week in terms of diagnostics and talking about Mount Kilimanjaro as we were going up the mountain. So I did want to throw this in terms of diagnostics. It is particularly helpful. This was a patient that we had that originally, when we looked at the PET scan, had stage 3B, we thought, lung cancer. In fact, this supracleft lymph node was actually just brown fat. So we definitely need to partner with our diagnostic colleagues to make sure that we are actually treating patients appropriately. So this is some of the stuff that we're working on now. 3D PET is what we're using today. 4D PET is what we're trying to get to so that, again, we can shrink our fields a little more, increase our dose, treat patients safer. And that's ultimately what our goal is as we kind of move forward. So there are still lots of imaging questions. When is a tumor actually within your field? Obviously, there's a lot of respiration that happens. Does motion change during radiation therapy? Whether that is due to infections or you respond to radiation therapy. How often should we remeasure this motion? Do patients start breathing less deep, more deep over time? And who would most benefit? What are these are big questions I feel like that we don't know the answers to. And before we put a ton of resources into it, we need to definitely do some research on it. Also, do tumors change shape during radiation therapy, second to second, day to day? So there's a lot of work that we still need to do in terms of radiation therapy for thoracic tumors. This is that example I mentioned earlier. This was a patient that had a cone beam CT. So we were doing daily low imaging cone beams, and you could see where the tumor sat and where a lot of this had collapsed. Over a 2-week period, this had kind of opened up. I will say that I wouldn't put this as a major selling point to add cone beam CTs. It is probably about 10% of the time that I actually have to replan patients, and maybe even less than that with thoracic tumors. But it is something that is nice when we do find that, because again, we can shrink our volumes and then treat a smaller area and have less complications. Other questions I think that come up for radiation oncology is normal tissue function and risk. There's a lot of differences between patients in terms of radiosensitivity, underlying diseases, often pre-treatment versus post-treatment imaging, and should we actually, instead of looking at dose volume histograms, look at dose function histograms instead, looking at actually what is functional lung and treat that area. We're starting to look at that and incorporate SPECT in our planning. Again, I think that this is very far off from prime time and something that still needs a lot of research that needs to be done before we want to add this technology, whether it's in the United States or anywhere in the world. So this is where our tumor sits right here in voxel and ventilated in a VQ scan. Again, right here, and so we were able to give a very high dose, and we entered our beams through this side, avoided all the functional lung that was happening that was nearby, and then we're able to kind of take the patient to a very safe dose by doing that. Again, same thing here in terms of ventilation. So it's very exciting that you have this stuff, but I don't, like I said, think we're ready for prime time on that. So key takeaways, kind of to summarize, I do think technology is going to help our patients. I don't think we all need to get on the bandwagon and start adding the latest and greatest, whether we're in the United States or whether we're in developing countries. I think careful attention to detail will be required to make sure we implement these technologies. And I think imaging is going to grow in importance in oncology. So thank you for your attention. Happy to take questions.